A very good afternoon to everybody, to the chairpersons. First of all, greetings from Kular Hospital, Bija, India. We have a small private setup, privately owned setup, doing laparoscopic surgeries from last 12 years. And I am into bariatric surgery from last 7 years. Started with Roux-en-Y gastric bypass in the beginning. So today I have to talk about the endoscopy and the fears of gastric cancer in Biloth 2 or mini gastric bypass. And in the last 6 years, we have 713 odd patients who underwent mini gastric bypass. And we are presenting the prospective study of these patients. If we see, mini gastric bypass is nothing but the same old Biloth 2 technique. The only difference being the stomach has been cut to a smaller size, small, long sleeve or tube kind of structure, and the length of the gastric bypass has been increased. Otherwise, it is basically the same Biloth 2. The special thing to note in this is that the gastrojejunostomy is low set. The level of the gastrojejunostomy is low, and probably that is the reason why we see less number of patients with bile reflux. If we see mini gastric bypass, it is spreading all over the world. Started by Dr. Rutledge about 15 years back. There are other surgeons in US who are doing it, and then we have Dr. Lee, Dr. Chevalier, and many others who have done thousands of mini gastric bypasses. What are the attractions of mini gastric bypass? First of all, the name goes by mini gastric bypass. The patients like it. But yes, we have to tell them that this is not a mini bypass, although the name has gone to be a mini bypass and the name looks attractive. But there are other things which are attractive in this. First of all, it's a short procedure. We take about 35 to 40 minutes to do a mini gastric bypass. It is simple because just one connection, just one gastrojejunostomy. And then it is as effective as the Roux-en-Y, as we see in these last 6 years. The maintenance of the weight loss is slightly better than what we see with our Roux-en-Y patients. And then on the top of everything, it is reversible and revisable as well. We had a patient who went into hypoproteinemia, and it took just 15 minutes to undo it. What are the fears? Bile reflux, marginal ulcer, the stomach cancer. In our series of this 713 odd patients, we had 2% of patients who had a documented bile reflux. And about 5% patients complain of gastritis. So we don't say that the bile reflux is not there. Yes, it is there, but in 2% of the patients we saw this. And out of this 2%, 95% of the patients, they improved with the prokinetics, with the antacids. So we don't really know exactly what is the cause of gastritis. Is it the same gastritis which we see normally in all the obese patients? Is it because of the acid or is it because of the bile? But definitely the antacids, the prokinetics, they improve the gastritis and the bile reflux. And we just had one patient with intractable bile reflux wherein we had to go in for a Roux-en-Y bypass, and that patient was diabetic as well, But for a report, I must tell you that that patient lost good amount of weight after mini gastric bypass. We converted him to Roux-en-Y because of the reflux. Now the patient is gaining weight. I don't know why. I mean, still, this is a question. Then the marginal ulcer. We have seen 2 patients wherein we could diagnose the marginal ulcers. Although we are not doing the routine endoscopies in every patient doesn't agree to go in for routine endoscopies, and it's not even indicated, as we see in Billroth 2. Nobody is doing normal routine follow-up with the endoscopies. So we are trying to do the endoscopies in as many patients as possible, and what we see is at 1 year, 2 years, 3 years, we don't even see little bit of gastritis at the GE junction. But yes, we had 2 patients wherein we had intractable marginal ulcers, but both these patients were chronic smokers. The stomach cancer, we didn't have any as yet. It's a very short-term data of just 6 years. About the fears of the bile flux and the gastric cancer, we have to go back to the history, to the 1960s, when the gastric bypass was actually started in US by Dr. Masons. He did a modification of the old Billroth 2. He decreased the size of the stomach and did a loop gastrogynostomy. And the result was a high incidence of bile flux. As it is very clear from the anatomy, we can see that the gastrogynostomy was very high placed. The distance between the GE junction and the gastric outlet was even less than 5 centimeters. But as we see, the Billroth 2 is still being done for many different kinds of indications, but we don't see that bile flux that common as was seen with the with the old loop bypass. So could be because of this reason, the name loop has got a stigma attached because of the Mason's loop. There was high incidence of reflux, and now whenever we talk about loop bypass, everybody thinks that it's going to give the same results. So this was the modification done for the Mason's loop. Roux-en-Y came into being and was considered as the gold standard. There was a review of the experimental data. It's published in the Arches Surgery, 2003. The objective was to rationalize the support given to the Roux-en-Y. And the conclusion was that the loop gastric bypass is a faster, similarly robust weight loss compared to the Roux-en-Y. If you want to compare the weight loss, it is the same. The complications are lesser, but yes, there are fears of reflux and gastric cancer. In the absence of ruling, the long-term effects of chronic alkaline reflux are unknown. We should not say that these are unknown, as Dr. Rutledge rightly said earlier, because Billroth 2 is more than 130-year-old surgery. And in this much time, all the effects should be known. So if we say that the effects are still unknown, that means that there are probably no significant effects. But the animal models and in vitro analysis of chronic alkaline reflux suggest that it can be carcinogenic. Probably that is the reason why we fear gastric cancer. with the loop kind of connection. This is the picture of the two patients wherein we saw the ulcers. There is something very important which I want to share with you. The ulcers were on the jejunal side. I don't know what inference we should draw from this. The ulcers were essentially on the jejunal side, and both these ulcers got treated conservatively with the antacids. So what I want to emphasize is that could be these are the same old peptic ulcers which respond well to the antacid treatment. And we did the endoscopies of both these patients after 6 months. We can just see small scarred area there. It looks pretty normal. So is there any need of routine follow-up with endoscopy after Bariatric or after mini gastric bypass? There have been series of studies about the endoscopies on Bariatric, and if we see all these studies show that it is futile to do endoscopy. The incidence of cancer detection after doing endoscopies on Bariatric patients, what we find is it is the same as we see in the normal population. About the gastric cancer, there has been no epidemiological evidence of increased risk after loop gastric bypass. This is by the Baber in Obesity of Surgery 2006. And there has been a great study, a meta-analysis of 22 reports. Dr. Rutledge also mentioned this study. But it again shows that there is no statistical evidence about this. And then a 25 years retrospective study by Fisher again shows the same thing. If we see already the gastric cancer, epidemiology of gastric cancer, the incidence is going down, the mortality is going down because of many other reasons. The same is the case with US, the same with the Japan, the incidence is going down. Could be because of many other associated factors like use of more and more use of vegetables, decrease in the nitrate content of the food because of the invention of the refrigerator. We don't need the processed meat now. We can keep the meat in the refrigerator and eat it like that. So maybe all these things have added up to a decrease in the incidence of gastric ulcer, gastric cancer world over. You can try to analyze any number of studies you want. The result is that gastric cancer and Bariatric, it may be and it may be not. Another study was done in Minnesota in 1983. 333 patients were followed up for 25 years to see the incidence of gastric cancer in the Bariatric patients. So if we see it was about 5,000 patient years which were followed up, and the end result was that the expected incidence should have been 2.6, whereas the actual incidence was 0.8. So it was even lower than what was expected in the normal population. But yes, we all know that Bariatric is done for gastric ulcers. And gastric ulcers are a kind of predisposing situation for gastric cancer. And all these patients, most of them they are cigarette smokers, and they have many other reasons why they develop the ulcers. And that is why we can expect a slightly higher risk of gastric cancer coming up again after Bilos 2 if it was performed for ulcer. And if we see this study of 1,000 Bilos 2 patients followed up for 20 to 30 years, still it is showing no increased risk. These are many other studies which show that there is no increased risk. But whenever we search for such kind of studies, we definitely come across a few studies which show that yes, there can be a slightly increased risk. But these are all the ulcer patients who are dealt with for the Bilos 2. And even if we see this study of 6,500 patients, it shows adjusted risk ratio of 1.28 only. If we see there can be increased risk of cancer in the gastric ulcer patients, but the overall incidence of gastric cancer is going down throughout the world, and there are many other factors which are coming up, like the H. pylori. You treat the H. pylori, you treat the gastric cancer. You treat the ulcer, you treat the gastric cancer. H. pylori has been well documented to be a major cause of gastric cancer. And diet has got a definite role. If you take a high vegetable diet, high vitamin C, citrus content, the chances of developing the stomach cancer decrease. Another study showing that vegetables and the fruits, they help decrease the incidence of cancer. And the same is true about the green tea as well. So to conclude, I just want to say that till date, there has been no strong evidence to suggest that yes, Bilos 2 would definitely cause cancer. No. There is no strong evidence like that. And so far as the results of mini gastric bypass are concerned, we see that there is very good weight loss. It's a very safe surgery. We don't see internal herniations. The many other problems which we commonly see with Roux-en-Y, which can even lead to death. A patient coming with internal herniation, going into obstruction, it's a threat to life. So all those complications we don't see in the mini gastric bypass. And the comparison of the risk which we fear of the ulcers and the gastric cancer, if you see these studies, even a baby aspirin can cause gastric cancer, gastric ulcers. The incidence, if you keep on taking baby aspirin for more than 10 years, the chances of developing the ulcer are more than what we see with the Bilos 2. So we conclude, there are many studies which find there is no increased risk, but ulcer definitely increases the risk of gastric cancer. So we have to treat the ulcers. We have to take down all those things which increase the incidence of ulcer, like smoking, alcohol, and add vegetables to your diet, and don't take processed foods, and treat H. pylori. These are the recommendations for our MGB patients. We ask them not to take cigarettes, alcohol, coffee, soft drinks, processed meats, and we promote them, we encourage them to take more and more yogurt, green tea, vegetables, and a low-fat diet. Thank you very much.
Thank you. I think there must not be any confusion. As you just proved, there is no increased risk of gastric cancer after a gastrojejunnal anastomosis done 200 meters down the ligament of threads. But the principal critics, which is done with the mini gastric bypass, is the risk of esophageal cancer due to bile reflux, which has been proven in experimental studies, but which doesn't happen with a regular mini gastric bypass because the gastric pouch is long and narrow, and there is no bile in the esophagus. Don't you agree with me?
Yeah, you're right. Yeah. All those studies which have been done on the animals, they show the increased risk in the esophageal cancer, not with the gastric cancer. And they were all esophageal actually. And if we see with mini gastric bypass, rather we have many patients. All of you know that most of the obese patients have some kind of acid reflux. But what we see, mini gastric bypass treats the reflux actually, because you have the GE sphincter upstairs, and it's a low pressure system. The outlet is wide, so the acid and the bile, it tends to go down. It doesn't go up in the esophagus. So that's why we say that it treats the reflux actually.
It is the big difference between the Mason Omega bypass that was done just on the esophagus, and the mini gastric bypass, which is done much more below. That's not the same operation.
No, this is the same as the antrectomy and no too.
There is another difference that, from my point of view, is even more important. There is no report on the relation between gastrojejunostomy and posterior cancer without stomach recession. You can review the literature. Always after a stomach recession for cancer or for ulcer. Even in the cases operated with Omega Blue by Mason, there is no report. I challenge you to look in the literature to find only one case in which a gastrojejunostomy is together with a time of operation in which the stomach is inside. All the reports are related to stomach recession.
You're very right here.
As I see it, because do you remember in Hamburg, Michel Suter reported on that, and you can look in the literature, and all the reports are related to stomach recession. In our case, we do not resect the stomach. We left, apart from the consideration that Jean-Marc Chevalier made before, that we play with the concept soft tube, soft intra-abdominal tube, which the positive intra-abdominal pressure collapse.
Yeah, you're right. Rather the reflux we see more with our sleep patients actually. The acid reflux is more, and there have been 2 case reports of cancer coming up in the esophagus after sleep.
You just...
I think
yes.
Excuse me. Thank you for this very informative.
Sure.
Just want to, did you compare the quality of life of the patient with mini gastric bypass and Roux-en-Y regarding like London syndrome, pain, renal pain, or this quality of life?
Yeah, we are writing a paper on this, the gastrointestinal quality of life index comparison of Roux-en-Y and the mini gastric bypass. And to be very clear, it starts from day one. Once you do the mini gastric bypass, you ask a patient who has got done a mini and who has got done a Roux-en-Y. The immediate progress after the surgery, the post-operative recovery, going home faster, and then the gastrointestinal quality of life is, as Dr. Lee has also documented, it is in the long run, if we see after 2 or 3 years, it's the same with Roux-en-Y and the mini gastric bypass. There's no difference in the quality of life as far as the gastrointestine is concerned, but there is a huge difference in the immediate post-operative recovery. The mini gastric bypass patients are up, they are out of the bed within 1 hour after surgery. They feel happier and more comfortable.
Last question for...
Pardon?
Dumping syndrome happens.
What? Dumping syndrome? Yeah, dumping syndrome is there, yes. But what I see is it's a kind of blessing disguise because I never saw a very serious dumping syndrome coming up in any of my patients, but we can say 4 to 5% of the patients complain of dumping syndrome.
Just one last question.
Thank you. I think that Dr. Garcia Caballero has pointed out a very important issue about the resection of the stomach. In one of the articles you have cited, the one from Tersmet, the Tiger group from Amsterdam in the early 90s, is published on cancer research. There are very interesting conclusions about that, and basically 4 conclusions. The first one is that there was no difference between operated and reconstructed patients with BILROT 1 or BILROT 2. This means that BILROT 1 is less refluxogenic than BILROT 2 is. There was no difference. And there was no difference between male and female patients. And the difference was if it was previously a gastric ulcer or a duodenal ulcer. This was the difference. So we are talking about different pathologies, but about the reconstructions, the results are similar. So probably is the gastric ablation, is the resection and the ablation of the stomach. Because there's one more article published in 2007 from a German surgeon, Senning, I remember, published on the European Journal of Surgical Oncology, that stressed out that after a great number of gastric resection, not only there was an increased risk of gastric stomach carcinoma, but always a risk of increased cancer in pancreas or in colon. And this is not related to the reconstruction. So I think this is the point.
So Professor Garcia Caballero will tell us his experience now. Thank you.